The objectives of this talk are for the learner to be able to identify key issues involved in counseling adolescents on different forms of contraception, and for the learner to be aware of recommendations for screening and treating sexually transmitted infections. We know that adolescents are having sex. Sometimes we don't like to think about this, but we know it's happening. The Youth Risk Behavior Survey is a nationwide survey of high school students. In 2011, it was found that 45.6% of high school females and 49.2% of high school males have ever had sex. Fully a third of both males and females have had sex in the past 6 months. And they also report that 46% of girls and 33% of boys did not use a condom during last sexual intercourse among the students who are currently sexually active. 77% of girls and 86% of males reported their partners did not use birth control pills before the last sexual intercourse. And 15% of girls and 10% of boys did not use any method to prevent pregnancy at last sexual intercourse. Clearly we have work to do to make sure that the teenagers are being protected when they are having sex. And as a practice, pediatricians aren't so great when it comes to talking about sex. A 2014 study in JAMA showed that 1/3 of annual exams of adolescents had no mention of sexuality issues. And in those annual exams where sexuality was discussed, the average time of the sexuality talk was only 36 seconds, which certainly does not seem adequate to cover all of these issues. Both the American Academy of Pediatrics and the American Medical Association recommend that providers have confidential time during adolescent health maintenance visits to discuss sexuality and counsel about sexual behaviors and risk reduction. Now, when you're talking with teenagers about these issues, it's important to set the stage and provide confidential care. We know that adolescents want confidential care. Many studies have shown how important confidentiality is in healthcare to adolescents. One survey showed that 1/4 of high school students would forego healthcare if they thought their parents might find out about their health concerns. And the most common reason for adolescent girls to miss needed healthcare was fear of their parents knowing about it. We know that adolescents are willing to disclose sensitive information and seek future care when assured of confidentiality. And I think sort of classically we think about this being sex, but it also includes things like substance abuse and mental health as well. The American Academy of Pediatrics, Society for Adolescent Health and Medicine, American Medical Association, American Academy of Family Practitioners, and American College of Obstetricians and Gynecologists all support confidential care for adolescents. And the National Research Council and the Institute of Medicine identified confidential care as an essential part of adolescent health services. I start every new patient and many return visits with a brief overview of confidentiality, and I discuss this in front of both the patient and their parents so there's no questions later. I also find it very helpful to ask the adolescent for a phone number where you can reach them directly in case you need to contact them after the visit, particularly when it comes to reporting things like the results of STD testing. The Guttmacher Institute is an excellent resource if you're not entirely certain what is legal to provide confidentially in your state, because the laws really do vary state by state. They also have a way to contact their staffers, so if you ever have any questions, you can contact them directly. The legal counsel for your hospital can usually guide you in this if you have questions about a particular patient and whether you're able to provide a particular service in a confidential manner. CDC recommends using the 5 Ps when doing a sexual history taking. That includes asking about partners, how many, male, female, or both. I often find that adolescents some may be a little surprised when you ask such explicit questions, and particularly when I ask, how many people have you had sex with? If there's a pause and I'm concerned that they're embarrassed about the number of partners, I'll often sort of throw out numbers, say 1, 5, 10, 50 partners, and then often they'll give you a little smile and they'll tell you the answer. The next P is prevention of pregnancy, as well as protection from sexually transmitted infections. You also want to ask about sexual practices. So you want to know, are they having oral sex? Are they having vaginal sex, anal sex? And sometimes they're not familiar with these terms, so you may have to actually say mouth on genitals and sort of explain these terms to them a little more clearly depending on their age and experience. In addition, you want to know if there's any past history of sexually transmitted infections and or pregnancy, because that might give you a sense of sort of how they've been doing protecting themselves in the past and things you might want to worry about moving forward. There have been over 200 risk factors identified for pregnancy and sexually transmitted infections, and unfortunately I will not be going through all 200 of them. Community and social disorganization are known risk factors, and that can include things like violence in the community or even hunger. Family disruptions such as a recent divorce or change in who's in the household. Household substance abuse puts an individual at higher risk, as does physical abuse. Younger age of mother and older siblings' age of first sex and childbearing put a patient, an adolescent, at higher risk of earlier onset of sexual activity as well. If a peer group is more permissive about sex, substances, and childbearing, that can influence an adolescent. Other risk factors include older peers and romantic partners, being behind in school, personal substance use, fighting or being part of a gang, depression or suicidal ideation, and sexual minority youth are also at risk. Moving on to contraception, when you're trying to think about what's the best option to discuss with your patient, you want to think about, is it safe for my patient and is it effective? If you're concerned about safety, there are two great resources out there. There's the 2010 CDC U.S. Medical Eligibility Criteria for Contraceptive Use and the 2009 World Health Organization Medical Eligibility Criteria for Contraceptive Use. The two documents have some minor differences, but they're very similar, and they run through lots of different medical conditions and rate whether a particular method is safe for that individual. And the rating scales for both the CDC and WHO documents are 1 through 4, where category 1, you can use the method in any circumstance. Category 4, absolutely method not to be used, and 2 or 3, somewhere in between, where 2 where you can generally use it, 3 not recommended, but it could be used if the other ones are not an option. In terms of whether birth control is effective or not, this slide here shows the percent of women experiencing an unattended pregnancy within the first year of use of this method. The most effective methods are at the top and going down, the most effective being the single rod contraceptive implant or Nexplanon, followed by the levonorgestrel releasing IUD, copper IUD, depo-medroxyprogesterone acetate or Depo-Provera, sort of the more traditional oral contraceptive pills, Ortho Evra patch, and Nuvaring, then the male condom, female condom, and least effective is the no method. And when you're counseling your patients, it makes most sense to start with the most effective methods and then move down from there. I think a lot of us often start with the birth control pills because they're the ones we're most familiar with, but in reality, you want to protect your patients. So starting with the most effective methods really makes the most sense. And the most effective methods are referred to as Larks, long-acting reversible contraceptive, and these really should be first line. These are the implant and their intrauterine devices. The ACOG committee opinion in 2007 said that IUDs should be considered as a first-line choice for both nulliparous and parous adolescents. And the AAP Committee on Adolescent in 2014 stated, given the efficacy, safety, and ease of use, Lark methods should be considered first-line contraceptive choices for adolescents. So I really would urge you to consider these for your patients. Nexplanon is the brand name that has replaced Implanon that many of us were familiar with. Nexplanon contains barium, so it's radio-opaque, so if you ever need to get an X-ray of the patient's arm, you'll be able to see it on the X-ray. Nexplanon is supposed to be easier to insert than the Implanon as well. Nexplanon, the advantages of it are that it lasts 3 years and there's nothing to remember in the 3 years, which is great. And it is, as that previous slide showed, the most effective form of birth control that we have. The disadvantages is that it does require an office visit for placement and removal, and some adolescents are sort of a little squeamish about anything procedural based, although you can reassure them that the skin is numbed and it's really not that painful. And adolescents also should be made aware that they may have irregular bleeding. It's usually not that heavy, but it is a real side effect, so they need to be forewarned ahead of time that this is something that may happen. Intrauterine devices can be used in women who have had children as well as women who have not had children. In 2005, the language was taken off of the copper IUD, stating that this is supposed to be only used in parous women. It can be placed immediately after a termination or a delivery. It can also be used if there's a history of sexually transmitted infections in the past and does not increase the risk of pelvic infections. Many people remember the Dalcon shield from a few decades ago in which there was a braided string, and some women, there was an increased rate of PID. However, the current IUDs use a monofilament. There is no increased risk of PID. However, you would not want to insert an IUD in someone with an active case of chlamydia, so you do want to screen for gonorrhea and chlamydia before placement. And once the levonorgestrel containing IUDs are placed, there's actually a theoretical decreased risk of PID due to thickened cervical mucus. IUDs, as noted previously, are extremely effective, and one additional advantage of the copper IUD is that it can be used as emergency contraception as well. IUDs are underutilized in adolescence but growing in popularity. This chart here shows the percent of U.S. women using an IUD among users of contraception, and it breaks it down by age group as well. And you can see in 1995, the rate of IUD use was incredibly low, and that actually was sort of the lowest rate of IUD use historically. But by the early 2000s, it started to rise again. It still hasn't gotten to the point of popularity that it's used in Europe, but it is becoming more and more popular among all age groups, including the younger ones, the 15 to 19-year-olds. There are 3 different IUDs on the market currently. There is the copper IUD, also known as Paragard, and then there are the 2 levonorgestrel-releasing IUDs, go by the brand name Mirena and Skyla. The copper IUD is great because it works 10 years, although it is reversible. So if in the 10 years the individual decides that they want to become pregnant, it can be taken out and fertility returns essentially immediately. It inhibits sperm motility, so sperm doesn't travel through the fallopian tubes. It also prevents the acrosomal reaction, so it doesn't fertilize the egg. And it also creates a sterile inflammatory reaction within the endometrium. So it's a very effective form of birth control. There are no hormonal side effects. Patients should be forewarned that they may have heavier periods and there may be a little bit more cramping, but patients sometimes like the fact that at least they still get their periods so they know they're not pregnant. It can also be used as emergency contraception, as I mentioned before. The levonorgestrel releasing IUDs, there are 2 different ones out right now. There's Mirena, which lasts 5 years, and Skyla, which lasts 3 years. They work by thickening cervical mucus. The sperm can't enter the upper reproductive tract. They also may prevent ovulation. About 5 to 10% of cycles become anovulatory. Patients with these levonorgestrel releasing IUDs often have lighter periods, which can progress to amenorrhea. So you would want your patient to know this, because sometimes teenagers, like, as I mentioned before, they like to know that they're not pregnant every month, but you can reassure them that it's okay to not get a period with this IUD, and they are incredibly effective forms of birth control, so they really shouldn't worry too much about pregnancy if they don't get their period. They also can treat menorrhagia. Since they do release levonorgestrel, they may cause some mild hormonal side effects. Mirena has more levonorgestrel than Skyla. Skyla has a quarter of the dose. So for people who are really concerned about the hormonal side effects, Skyla may be the better option. DMPA, or depomedroxyprogesterone acetate, or Depo-Provera, sometimes just referred to as the shot, is also an effective form of birth control. The advantages of this kind is that it's very discreet. It's a shot. No one can see that you're getting it. It's every 3 months, so it's not something you have to remember all that often. It's a very effective form of birth control. Many of these patients also eventually progress to amenorrhea, which some patients think is great, but as I mentioned before, some patients don't like that so much. The disadvantages is either you have to be able to get to a clinic every 3 months, and some patients are worried about being able to do that and being able to remember to show up on time in their window. For the first 2 cycles or 6 months, it's very typical to have irregular bleeding. It's usually not super heavy, but it can be kind of annoying. So again, this is something that you want to counsel your patients about so they're not taken by surprise about this. There is also an FDA black box warning about bone health with Depo-Provera, and concerns that there is bone loss while patients are getting Depo-Provera, which may not be completely reversible. There is no recommendation at this time for patients with Depo to get bone mineral density tests as screenings. I do encourage patients who are receiving Depo, though, to make sure that they are getting sufficient calcium and vitamin D in order to try to protect their bones. Also, some patients gain weight with Depo-Provera. It seems to be the patients who start out slightly overweight in the first place are the ones who gain the most amount of weight. Next, we move on to the estrogen and progesterone methods. And so there are sort of 3 ways that these medications can be administered. One is through the traditional pill, one is through a patch, and one is through a vaginal ring. The advantages of all 3, they often help with acne and hirsutism. They often decrease menstrual cramping and flow. Periods are usually very predictable, which patients like. Despite everything that you may find on the internet, weight gain has not been a really well-documented side effect. Population-wide studies often show that women on and off the pill both gain weight, but they gain weight at the same rate. So women who are on the pill tend to blame it on the pill, and women who are not on the pill find something else to blame it on. But I do try to reassure patients that there really isn't weight gain, and if they just stick to their whatever they're doing for their eating habits and exercise currently, they should be fine. There's also a decreased lifetime risk of ovarian cancer. The disadvantages is there's sometimes what I refer to as nuisance side effects, particularly in the first couple cycles. Patients may experience breast tenderness or headaches, nausea, or anorgasmia. There's some concern about increase in blood pressure, and I think the thing that most of us worry about is the increased risk of thrombosis, which fortunately is rare but is real. And the CDC and WHO medical eligibility criteria both take this seriously as well, and there are certain people who are considered too high risk for thrombosis, so they're either encouraged to get another form of birth control or told not to use this form at all. The ones that rated level 4 on that 1 through 4 scale, now remember level 4 was absolutely don't use this. Patients with a personal history of a PE or DVT, both CDC and WHO say that if they're at a high risk of recurrence, then they should never use this form. CDC says if they're at low risk, then you could potentially consider it, although WHO says no. A family history, such as a first-degree relative with a PE or DVT, interestingly, they're both 2s, so if the father had a PE of unknown causes, that doesn't mean that the daughter can't ever try this. Often what I'll do is try to find out more information about why the parent or whatever first-degree relative had this event. If it's been identified as a particular mutation, such as factor V Leiden, you could screen the patient for that one, but if no particular mutation has been identified, you need to think carefully whether you want to screen people for mutations such as that, because just because a hypercoagulation panel comes back negative doesn't mean that the patient doesn't have something that's not on the panel. Other issues that are brought up are major surgery. If it's without prolonged immobilization, you can continue this, but if there's going to be prolonged immobilization, you would not want to be on a combined hormonal method. Antiphospholipid antibodies are also a contraindication. For patients with a migraine without aura who are less than 35 years old, you can use these, although all patients with migraines are at slightly higher risk of ischemic strokes on this form of birth control. However, if the patient has a migraine with aura, you are absolutely not supposed to use this form due to an even higher increased risk of stroke. A family history of breast cancer is rated a 1, so you absolutely can give this method, which can be very reassuring. I find a lot of times for mothers who are very worried about this, particularly if they either had breast cancer or there's a strong family history of breast cancer. I should also point out that this rating scale is looking at using these methods specifically for contraceptive reasons. So there are other women who are put on birth control pills, perhaps because they're on chemotherapy or some sort of anticoagulation medication, and they're at high risk of serious hemorrhage or high risk of hemorrhagic ovarian cysts if they're not on it. So that would be a different risk-benefit ratio that you'd have to think through. These CDC, WHO ratings are specifically looking at using these methods for contraception. So the combined birth control pills, I think one of the major pros is that they're a very familiar form of birth control. Patients will have friends or sisters or mothers who have used this. We have many years of experience of this form. There's even a chewable form, which has a mint flavor, I believe, if you're unable to swallow pills. I think the major disadvantage is you have to take it every day without fail, which a lot of teenagers have never had to take a medication chronically before, so this is a new thing for them. And parents, sometimes if it's being done confidentially, the kids are worried their parents might find the pill pack and know that they're having sex. It's also not as effective as the other methods like the Larks or the Depo-Provera, which is worth telling your patient. In terms of which pill to prescribe, I generally say whatever pill they're willing to take is the one you should prescribe. So sometimes I'll ask them, is your sister on one? Is your friend on one? What have you heard? What have you heard they like? What have you heard they don't like? If there's a pill that they come and they're saying, I want to be on this pill, unless there's some specific reason why I don't want them on that pill, generally I'm fine with prescribing them. It may also be worth considering the cost issues. Target and Walmart both have really cheap generic pill packs, so that's a good place to start. I generally start with a monophasic pill with either 30 or 35 micrograms of ethinyl estradiol. I tend to like monophasic pills in teenagers because I think they're a little easier. When you have the triphasic pills, I think it just gets a little more complicated, and I think for the first time someone's on this kind of medication, just keeping it as simple as possible is a good thing. In terms of which progesterone, levonorgestrel or norgestrel is often considered the most potent progestin, so it might be good for a patient who's experiencing some dysfunctional uterine bleeding. Norgestimate-containing pills are great for patients with PCOS kind of symptoms like acne or extra body hair. Desogestrel, I tend to not use as much because it has a higher clot risk than those other two. Drospirenone is great for PCOS as well, but also there has been concern about this higher risk of blood clots, with the FDA following this quite closely. So what is the evidence about this? A study in 2011 showed that the venous thrombotic risk in those using a birth control pill with drospirenone compared to levonorgestrel had a relative risk of 2.1% of having a blood clot. Now, a follow-up study by that same group sort of looked at what does that risk mean, and they found that 2,000 women would need to change from a drospirenone-containing birth control pill to a different form of birth control in order to prevent one venous thrombotic event. So it is still a low risk, though. The FDA surveillance report from 2011 showed that the venous thrombotic risk in those using drospirenone compared to a 20 to 35 microgram estrogen-containing birth control pill showed an increased risk of 1.74. A follow-up report from the FDA in April 2012 reported drospirenone-containing birth control pills may be associated with a higher risk for blood clots than other progestin-containing pills. And a recent study in Contraception in 2014 actually showed a different outcome, though. It showed a similar risk of venous thrombotic events in drospirenone-containing pills compared to birth control pills without drospirenone. So it's something that is still being looked at. But I think it's important to keep the perspective that all birth control pills have a higher rate of venous thrombotic events than not being on a birth control pill. But it's still a lower rate of venous thrombotic events than were the patient to get pregnant. So again, it's sort of weighing the cost benefit ratio just like you would with any medication. So I just make sure that I document, if I do prescribe a drospirenone-containing pill, that I document this discussion with my patients and make sure they know the warning signs for blood clots. So how do you start the pill? There are lots of different ways to start the pill. I tend to like doing a quick start where they start it that day. The advantages of that is that it starts that much sooner, so you get birth control coverage that much quicker. However, you do need to tell them that they'll need to use backups, condoms for the next 7 days. The other disadvantage is that depending on where they are in their cycle, they may have irregular bleeding the first month, so you'd want to warn them about that. Another option is to do the first day of their next menstrual period. The advantage of that is that you don't need the backup for the 7 days, and the period should be nice and regular from the start. However, you then have to wait for their next period in order for them to have that contraceptive coverage. Another sort of, I think probably the most traditional way to start a pill, which probably I find most moms are familiar, is starting the first Sunday after the next period. However, the thing to warn about that is that you need to use backup for 7 days if it's been greater than 5 days since their period started. So this is very problematic for patients who get their periods on Mondays, because if they wait until the next Sunday, they have to use backup, and sometimes it's hard to remember when you need to use backup, when you don't. The other thing that I don't like about doing the first Sunday start is that means that their prescription runs out on a Sunday. And if they haven't thought ahead about whether or not they need to get a refill from their doctor, that means they need to track someone down on Sunday to get a refill, so that way they don't have a gap in coverage when they run out of their next pill pack. The counseling is really important when you start any new medication, and particularly with birth control pills. You want to make sure that you tell your patients they still really need to use condoms, because birth control pills aren't 100% in preventing pregnancy, so using 2 methods is always better than 1. In addition, birth control pills don't do anything to prevent sexually transmitted infections. If you have a sample pack, show it. If you don't, draw a picture of one. Often patients have seen them. I often tell them they come in sort of 2 different styles. They come in a circle or they come in rows. And I literally show them sort of how you march through a pack with taking a pill every day. And make sure they know that even if they're bleeding at the end of the placebo week, they still need to start the next pill pack, because I find that some patients wait until the bleeding is stopped to start the next pill pack, and that's actually too late. If you have a handout to sort of reinforce these instructions, give it to them, because it's a lot to take in on the first visit. I do let them also know that sort of those nuisance side effects, the headaches, the breast tenderness, the nausea, usually go away in 2 to 3 months. And if they are experiencing those, I ask them to kind of try to tough it out, because if you're constantly switching from pill formulation to pill formulation, you never sort of are able to let your body equilibrate to the effects of the birth control, and sort of often those side effects would have just passed anyway. Aches is a good way to remember the warning signs of blood clots. So A is abdominal pain, C is chest pain, H is headache, E is loss of vision in an eye or pain, and then S is severe swelling or pain in the leg. A lot of teenagers have little aches and pains, so I tell them, this isn't just a twinge, this is sort of the worst pain of your life kind of thing. I tell them, don't fool around, just go immediately to the emergency room, tell them that you're on a pill and this is what you're worried about. In terms of actually taking the pill, for someone who's not used to taking a medication every day, I often recommend using a cell phone alarm clock to help them remember, because, like I said before, it can be tricky to take a medication if you're not used to it. Also going over what to do if they miss a pill, and then I have them come back in 3 months just to check their blood pressure and see how they're doing. If at that point they're still having some side effects they're really unhappy with, whether it's breast tenderness or perhaps, usually it helps with acne, but some people find it actually worsens acne, then I'll switch to a different pill formulation. And I let them know that. I let them know that there are lots of different pills on the market, so if there's something about this pill that we're trying first they don't like, we have lots of ways to adjust it, so not to give up. And then moving on to the Nuvaring. This is very similar to birth control pills in terms of how it works. It contains estrogen and a progestin. There are sort of two different ways you can use it. The on-label way to use it is you have it in for 3 weeks and take it out for a week. Taking it out for a week is the equivalent of the placebo week in a pill pack. And then after 1 week out, you start the next ring. An off-label way to use it is just to leave it in for a month. On the same day of the month every month, take it out and immediately put the new one in. The advantage of doing that is that you only have to remember it once a month instead of remembering, 3 weeks and then a week. So you can just decide, first day of the month is my ring day. And there is enough medication in the ring that it's okay that for the 30 and 31 day months that you're leaving it in for more than 28 days. For the squeamish, they can use a tampon applicator for insertion. I'm always surprised at how squeamish adolescents can be who are using it for birth control, so therefore are having sex, but they do not feel comfortable putting things in themselves. You can let them know that it can be out of the fridge for 3 months. Often when it's picked up at the pharmacy, it's cold because the pharmacists keep it in the fridge. And that's just because the pharmacists don't know how long it's going to be until they dispense it from the pharmacy. So they have to keep it refrigerated. But the patient can leave it out of the fridge for 3 months, which is particularly good for those patients who don't want their parents to know that they're using birth control. Putting their birth control form in the fridge would be a pretty good giveaway. But it should really only be out of the vagina for 3 hours once they start using it. So I tend to not advertise the fact that it can be taken out for 3 hours because 3 hours often becomes 4 or 5 or 6 or forgotten to put back in, but it can be, if it ever falls out, it can just be washed off in a little water and put back in. Teenagers worry that they might feel it during sex. Studies have shown that most people do not feel it during sex. The advantages of the Nuvaring is that it's discreet as well. No one knows you have it in there. You only have to remember once a month. Major cons, you have to be willing to touch yourself. As I mentioned before, some teenagers are kind of squeamish. And some complain of physiologic discharge, but it doesn't put you at higher risk of bacterial vaginosis or yeast infections or anything like that. Ortho-Evra is the patch. Also contains an estrogen and progesterone. It does have 60% more estrogen than a 35 microgram pill. And the way this is used is it's 1 patch a week for 3 weeks and then 1 week with no patch. And it can be it can put anywhere in the body basically except the breast, so the back, the buttocks, the legs, the upper arms. And the patch can be off for up to 24 hours. You do want to tell them that they don't want to put it on the same site every week, so they want to move it. But if they want to always have it, say on their back, they can do the left side of their back 1 week and then the right the following week and then back to the left for the 3rd week. That's not a problem. The advantages of the patch is that it's relatively discreet, particularly in the winter when you're covered up. But even someone who's going to the beach in the summer, usually bathing suits cover up the butt, so they can just put it on their buttocks. You only have to remember once a week instead of the everyday pill. The cons are that some studies have shown a higher rate of venous thrombotic events than birth control pills. FDA looked at this as well, and a surveillance study showed a relative risk of 1.55 of venous thrombotic events in those who were using the patch as compared to those using a 20 to 35 microgram pill. Some patients complain of some contact dermatitis just from the adhesive of the patch. Some get some discoloration. I think a major disadvantage is that it only comes in one skin tone, and it's a pretty pale Caucasian skin tone. In addition, it should not be used if the individual is greater than 90 kilos because it would not be effective. The progesterone-only pill, sometimes referred to as the mini pill, this is also an option. The advantage of this is that you decrease blood loss and cramping with periods. It's a pill option for those who can't use a combined contraceptive pill, like those with migraines with aura or a personal history of a blood clot. About 10% of women with the mini pill become amenorrheic, again, which may be a con. The cons are that this one really has to be at the same time every day. With the traditional birth control pill, there's probably a little wiggle room, but the mini pill, it really has to be within the same 3-hour window every day. And if you miss it, they have to know that they really need to use backup for at least the next 72 hours.
Some patients experience spotting with this, not really heavy spotting, but again, kind of annoying, so you'd want to warn the patients about this ahead of time so they're not concerned. And the timing of periods are not as reliable as they are with the traditional estrogen progesterone containing pill. You also want to make sure that the users realize that all the pills are active. There is no placebo week. Patients who, for whatever reason, you're switching from a traditional birth control pill to the mini pill, they all know it's a placebo week. A lot of them just skip the placebos because they figure why bother. But it's important that someone who's on the mini pill understands they really need to take it every day. Barrier methods are nice because they provide both contraception and prevention of sexually transmitted infections, although the efficacy of the contraception is not as high as with the other methods that I previously discussed. They can require some negotiation between partners, which can be hard for some adolescents. And they're probably trickier to use correctly than most adolescents and probably adults are aware, which is likely why typical use and perfect use efficacy of these methods, there's significant difference between the two. The male condom, I think, is a very familiar format. They're cheap. They're about 50 cents for latex. They're a little more expensive for polyurethane for patients who have latex allergies. And also the polyurethane ones can be a little harder to find. Sometimes CVS and other pharmacies don't stock it, but they are available easily online. Condoms come in a variety of styles, colors, flavors, so they can sort of play with different things. It is important to discuss proper use. And that means putting the condom on an erect penis, leaving room at the top, rolling down the penis, and then removing from the penis while it's still erect. They need to know there's an expiration date on the condoms. They don't want to put them in their back pocket or in their wallet because there's some concern that the heat from the body could potentially cause some breakdown of the latex. And condoms are very familiar to teenagers. 2009 data showed that 44% of female students and 60% of male students report using condoms at last sex. So this is a very comfortable option for many teenagers. Female condoms are, I think, haven't become nearly as popular as male condoms. The initial female condom was made of polyurethane, and it made, I've been told, a sort of a squeaking noise during sex, which some people did not like. The second generation one is made of a synthetic latex, which I believe has resolved some of the squeaking noises. But they are more expensive than male condoms, sort of in the $3 to $6 range. But the one nice thing about them is that they are very much female controlled, so the woman can kind of just do it and requires a little less negotiation with the male. Another advantage is that they can be put in up to 8 hours before sex. What you want to do is compress the inner range and place it high into the vagina until the outer ring rests against the vulva. You remove it immediately after intercourse by twisting the outer ring to seal it and then pulling it out. You would not want to use male and female condoms together due to theoretical increased use of breakage. And many are really unaware this option's even out there, and counseling has been shown to increase usage, so it's certainly worth mentioning to your patients. Emergency contraception, it's sort of a slightly different category than contraception, but I still think it's just worth covering briefly. The copper IUD is the most effective, but for some patients, hard to find someone who can place a copper IUD in a time-sensitive manner. Levonorgestrel, I'll go for the brand names Plan B, Next Choice. It's 1.5 milligrams as soon as you can after unprotected sex. It used to be thought that you'd give 0.75 separated by 12 hours for a total of 2 doses, but now it's just give the 1.5 times 1. It inhibits ovulation and thickens cervical mucus, does not cause an abortion. It only works before the LH surge, so depending on where they are in their menstrual cycle, it may be ineffective. As I mentioned, you want to take as soon as possible. There is some effect up to 120 hours, so 5 days after the unprotected sex, but it's only FDA indicated for the first 72 hours, so that's what it says on the packaging. So if you're recommending for your patient to use it in the 73 to 120 hour window, I think it's worth just saying to the patient, the packaging is going to say 72 hours, but there's probably still some benefit even if you take it a little later than that. Recent data, however, is particularly concerning for patients who are overweight. It's not effective for patients that are overweight. It is now over the counter for those 17 and older, but I find sometimes you can give a prescription to get insurance coverage because it's not all that cheap. Another option for emergency contraception is Ulipristal Acetate, or ELA. This is also a one-time dose and is a progesterone reception modulator. It's a synthetic progesterone agonist-antagonist, and it works both before and after the LH surge. So it's nice that it works throughout the menstrual cycle as opposed to the Plan B, which is just before the LH surge. In addition, there's some data showing it's more effective than Plan B, specifically during the 73 to 120 hour window. So for the patient who comes to you kind of on the later side, this is worth thinking about, particularly for the patient who's overweight as well. But you do need a prescription for this. So this is one of those circumstances where talking with your patient ahead of time about the option of emergency contraception, potentially giving them a prescription that they could fill and just keep in their sock drawer so they have it in case they need it someday. So that way they don't have to delay usage by tracking you down, potentially making an appointment or not, getting you to call the prescription in, because time is of the essence with these. Okay, so moving on to sexually transmitted infections. We know that adolescents and young adults definitely get STDs. 15 to 24-year-olds are at higher risk of developing STDs than other age groups, and there are biological reasons behind this. Cervical ectopy in females increases susceptibility to chlamydia, and there are social factors, some which I discussed earlier, but lack of access to preventive services and concerns about confidentiality are major as well. And while 15 to 24-year-olds are only about a quarter of the sexually experienced population in the United States, in 2000 they accounted for almost half of all new sexually transmitted infections, so clearly a very high-risk group. Treatment guidelines are available. I highly recommend looking at the CDC website. It's really user-friendly. It goes through all sorts of different STDs, talks about how to properly test and treat. There's also an ebook you can get for your iPhone, so you always have it on you if you need it. It's a really great resource. So chlamydia is the most frequently reported sexually transmitted infection in the U.S. And unfortunately, there are no symptoms in 3/4 of females and half of the males, which is probably why it's so common. But if there are symptoms, it might include things like dysuria, vaginal or penile discharge, abdominal or back pain. And chlamydia can cause several clinical symptoms, including cervicitis, urethritis, which in the males might be dysuria and or discharge, epididymitis or proctitis, bartholinitis, PID, or perihepatitis. And now we worry about chlamydia because the sequelae can be pretty severe. Pelvic inflammatory disease can be very severe in some patients with a significant amount of pain. It can cause scarring, putting patients at risk later on for ectopic pregnancy and infertility. You worry about in pregnant patients about premature rupture of membranes and low birth weight, and you worry about neonatal infections if a pregnant mom has it at the time of delivery. If a picture's worth 1,000 words, here's a picture of chlamydia cervicitis. You can see sort of pus just coming from the os. In terms of screening, the recommendations are that all sexually active women less than 26 years old should be screened at least annually, so that's all teenagers who are sexually active. And women who are 26 or higher who are considered higher risk, including new or multiple sex partners, should also be screened annually. For men, there is the government says there's evidence insufficient to recommend routine screening in men, but should be considered in clinical settings with high prevalence of chlamydia, such as adolescent clinics where I work, jails, STD clinics. I think it's good to err on the side of caution, and if you have any concerns, certainly screen for this. Chlamydia is an obligate intracellular parasite. The best way to test for it is a NAT, or nucleic acid amplification test. This is both highly sensitive and specific. The recommended site for NATs are vaginal swabs for women or first void urine samples for men. And now the vaginal swab can either be done by the provider or by the patient. I give my patients the option, and I'd say maybe 1/3 of the patients want to do it themselves and 2/3 want me to do it. And it's very simple to do. I just explain them how to do it, and it works great. It can also be used with urethral and cervical samples. I think that particularly, for the women, it can also be used as a urine sample, but the vaginal swab is so easy. And if you have something like dysuria, it's great because you can use a clean catch urine for a urinalysis or urine culture, and then the vaginal swab for the chlamydia. And you don't have to worry about trying to get a dirty catch and a clean catch urine, which can be a tricky thing to do. Most tests are not FDA cleared for rectal or oropharyngeal swabs, but the CDC still recommends NATs for extragenital sites. They are the most sensitive and specific method we have, and CLIA waivers are available for labs to do the extragenital site testing for purposes of treatment and reporting to the government. You want to use culture, though, if you're concerned particularly about sexual abuse or rape, because culture is 100% specific. There are a couple different treatment options for chlamydia. The recommended regimens are a one-time dose of azithromycin. I think this is definitely the preferred one because you can actually give it in the office. It's quick. You don't have to remember anything beyond the first-time dose. Major side effect is nausea and vomiting, so if the patient does throw up within 30 minutes of taking it, you should repeat the dose.
For doxycycline, it's 100 milligrams twice a day for 7 days. There are alternative regimens for the rare patient who has both an azithro and a doxycycline allergy. Expedited partner therapy is when you prescribe antibiotics for sex partners of patients with chlamydia. So it may be that the partner is not your own patient, but you can still prescribe them the medication. It is safe and effective, and it is more effective in reducing persistent and recurrent chlamydial infection than traditional partner notification, in which the partner notifies their patient, when the patient notifies their partner, that the partner then needs to go to their own doctor and get tested and treated, and there's probably some lapse time between when you're a patient and their partner gets treated, and there's risk that in that intervening time they may be passing the infection back and forth between each other. The CDC strongly recommends EPT. 30 states have laws that permit or may permit EPT under specific circumstances. I practice in the state of Massachusetts, and EPT is allowed. I am able to write a prescription either to EPT or expedited partner therapy. I don't need the partner's name. I don't need the partner's birth date. And what happens is I give the prescription to my patient, who then gives it to his or her partner, and the partner then brings it to the pharmacist, who is supposed to fill it, no questions asked. 23 states have laws that may limit or prohibit the use of EPT. This changes all the time. The CDC keeps a nice website where you can go to it and look to see whether you're able to do this in your state or not. Moving on to gonorrhea, it's an intracellular gram-negative diplococci. Patients may be asymptomatic, particularly if with throat or rectal gonorrhea, or they may have a purulent discharge, but often no symptoms are present until their complications. And the complications can include PID, Bartholin abscesses, disseminated gonococcal infections, migratory arthralgias, tenosynovitis, polyarthritis, hepatitis, meningitis, or endocarditis. A diagnosis of gonorrhea is also a NAT. Typically, the NAT tests, it's one test for both gonorrhea and chlamydia. So the recommended diagnostic test is basically the same as chlamydia. So it's the vaginal swab for women. The first void urine for men is optimal, but again, it can also be used for cervical, urethral samples. And again, not cleared for extragenital sites, but CDC still recommends it. In cases of documented treatment failure, though, you do want to perform susceptibility testing because, unfortunately, there have been some reports of resistance to the traditional treatment methods, which is of concern to many people. In terms of who should be tested, the U.S. Preventative Task Force recommends the gonorrhea, chlamydia only in those increased risk for infection. So that would be a woman with a previous STI, someone who has new or multiple sex partners, so that would pretty much be all adolescents, inconsistent condom use, so again, probably most adolescents, commercial sex work, drug users, and those living in communities with a high prevalence of the disease. If someone does test positive for gonorrhea, you want to make sure you test them for other STIs, including chlamydia, syphilis, and HIV. In terms of treatment, you want to give ceftriaxone 250 milligrams IM once, and then either azithro 1 gram once or doxycycline 100 milligrams twice for 7 days. And the reason that you do both medications is twofold. First, to cover co-occurring infections that are very common, like chlamydia. But even if you know that the chlamydia test is negative, you still want to give both drugs because the two-drug method is hopefully going to delay emerging gonococcal resistance. And oral cephalosporins are no longer first line due to concern of waning efficacy and does not provide as high bactericidal levels, particularly in the pharynx. And there's also concern that there is rising resistance to oral cephalosporins, and if we allow that rising resistance to get worse and worse, this may then bleed over into the ceftriaxone resistance as well, and then we would lose that as a drug. Quinolones haven't been recommended since 2007 due to widespread resistance. If you do have a patient that you're concerned about resistance, it's also worth taking a travel history because many of the documented resistance cases have been seen in Japan. I think there was a case in Hawaii. So if someone was recently on vacation and had sex somewhere on vacation, that's something else that you would want to consider. What do you do after you treat them? You tell your patient that they shouldn't have sex for 7 to 14 days. The reason is, let's say your patient gets treated and then has sex with their partner who's not yet treated. The infected partner would then pass it back to your patient, and then if the partner gets treated after that, your patient would then give it back to their partner. So you want to tell them both, no sex for 7 to 14 days until after both have been treated.
In terms of a test of cure, that's really only done for pregnant women or if there's some specific concern you have about compliance or their symptoms persist or reinfection is suspected for some reason. However, CDC does recommend retesting 3 months after treatment for test of reinfection because this situation where the partners don't wait long enough before having sex after both were treated is actually very common. In terms of which partners need to be tested, you want to evaluate, test, and treat any partners within the last 60 days, or if your patient hasn't had sex for more than 60 days, whoever their last partner was. HPV is the most common STD in the US, and as you can see, it has the highest prevalence in the 20 to 24-year-olds. HPV can present as genital warts, which can be on the cervix, vulva, penis, scrotum, vagina, urethra, or anus. They may persist, they may recur despite treatment, they may regress spontaneously, or they may undergo malignant transformation. And of course, the thing we worry about is the cervical intraepithelial neoplasia and other genital cancers. And there are more than 10,000 new cases a year of cancer related to HPV. And for those with cervical cancer, unfortunately, half of these patients had never had a Pap test. Here's some pictures of some penile warts and some female genital warts. In terms of testing, there's no culture for HPV. You don't use serology because only half or a little bit over half develop detectable HPV antibodies. And you only use HPV DNA test as part of Pap tests. It detects DNA in people who are actively shedding and is designed to determine if a woman has or will develop cervical intraepithelial neoplasia in the next 2 to 3 years, not as a test of an STD, just to see if they have HPV. And it should not be used in healthy women who are less than the age of 20 or men. Management, there are several different options. There are patient-applied regimens and there are provider-administrated regimens. No one treatment is better than the other, so often it boils down to provider and patient choice, so it's worth having a discussion if you are able to offer any of the provider-administrated regimens, or you can try one of the patient can try one of the patient-applied regimens. Just because a patient has genital warts, this does not change Pap smear guidelines. You still get them according to the traditional routine. And it's worth counseling the patients that condoms are only partially protective because HPV is spread by skin-to-skin contact, so a condom really only covers the penis. So if there were some warts on the scrotum or on the female's vulva, they could still get passed that way. The best way to treat HPV is to prevent it from ever happening in the first place. So vaccination. As I'm sure everyone's aware, there are 2 HPV vaccines on the market. There's HPV-4 by Merck Gardasil. It does strains 6 and 11, 16 and 18. 6 and 11 cause 90% of genital warts. 16 and 18 cause 70% of cervical cancers, as well as cancers of the vulva, vagina, penis, anus, and likely throat and mouth in men and women. It's licensed for males and females aged 9 to 26 and has a 0, 2, and 6-month dosing schedule. HPV-2 or Cervarix only has 16 and 18 and is licensed for females on a 0, 1, and 6-month schedule. Unfortunately, HPV vaccine uptake has not been great. Adolescents are not receiving this despite it being one of the routinely recommended vaccines. As of 2013, only 37.6% of the girls aged 13 to 17 in the U.S. had completed the series, and only 13.9% of boys had completed the series, which is pretty abysmal. And parents are increasingly not planning on vaccinating their daughters, unfortunately. In 2008, 39.8% said they did not intend to vaccinate with this vaccine, but by 2010, it was up to 43.9%. That they did not intend to vaccinate. And the study's looking at why aren't patients getting immunized. A 2010 study, the top 3 reasons why parents of their daughters had not received the vaccine was that it was not needed or recommended. And clearly, as providers, we are not doing a good job because it is needed and it is recommended. And a significant number were concerned about safety concerns or side effects, or that their adolescent was not sexually active. In terms of safety, we know these vaccines are safe. Prior to licensing, both vaccines were given to thousands of people around the world. Gardasil was given to 29,000 men and women, and Cervarix to 30,000 women. As of June 2012, more than 46 million doses of HPV vaccine have been given in the U.S. There has been very close safety monitoring, as there is with any vaccine. We know the common side effects. They're pain at the injection site, and this one does seem to hurt more than the average vaccine. Fever, dizziness, and nausea. Fainting after vaccination is more common in adolescents and adults, but that's true for other adolescent vaccines like the meningitis vaccine. A 2011 surveillance study showed there was no increased risk of strokes, seizures, anaphylaxis, blood clots, appendicitis, or Guillain-Barré syndrome, or whatever crazy thing is going around the internet right now. And as we know, in the U.S., adolescents are having sex. 1/3 of all 9th graders and almost 2/3 of 12th graders are having sex. So for parents, they say that their child does not need this because they're not having sex. The reality is that a lot of teenagers are having sex. And some parents are worried that
if they let their child have this vaccine, that they're then giving tacit permission for their teenager to have sex. Studies have shown that adolescents do not perceive receiving the HPV vaccine as parental permission to have sex. There was no increased risk of sexual activity-related outcomes such as pregnancy or STDs in 14 to 15-year-old girls who had received the HPV vaccine at age 11 to 12 compared to those who had not received the HPV vaccine. And then the my child is low risk. HPV is so common, and the cancer-causing strains often do not have any symptoms, so they're unaware that they're affected with HPV. And as I said, it's spread by skin-to-skin contact, so condoms may lower the risk, but HPV can still infect areas not covered by a condom. It's estimated that 50 to 80% of people will be infected with HPV at some point in their lifetime, even if they wait until marriage to have sex. And a study of 16-year-old girls who on average had 2 years of sexual activity detected cervical HPV in almost 2/3 of them. So that's my little spiel on HPV. Moving on to bacterial vaginosis and trichomonas. Both bacterial vaginosis is not technically an STI, while trick is, but both can cause a malodorous vaginal discharge with an elevated vaginal pH of greater than 4.5 and a positive whiff test, which is when you put KOH on a sample and you get that fishy smell. Both can be diagnosed by a wet prep, both can be diagnosed by vaginal culture and Pap test. And GenProbe's Aptima recently, or 3 years ago, was approved for trick as well. BV, the treatment, there are several different options. There's metronidazole, either orally or as a vaginal gel. I often give patients, ask them which they prefer. There's also a clindamycin cream that can be used intravaginally. New options from the 2010 STI treatment guidelines include tenadazole, which is nice because it also treats trick, as well as clindamycin orally or clindamycin ovules. Since BV is not an STI, it's really just an alteration in normal vaginal flora. The partner does not require treatment. Trick, there are several oral options, including different dosing of metronidazole or tenadazole, and since this is an STI, the partner should be treated. Herpes simplex virus, also a very common STI. Some patients it's asymptomatic, but you may get vaginal or penile discharge, vulvar edema, perineal pain, dysuria, urinary outflow tract obstructions, painful or itchy ulcers or vesicles, dyspareunia, tender lymphadenopathy, or other systemic symptoms. There are 2 different strains of herpes that can cause genital symptoms, HSV1 or HSV2. And it can be worth knowing which your patient has because the distinction influences prognosis and counseling. There is less subclinical shedding and fewer recurrences with HSV1, and it has an overall milder course with HSV1 as compared to HSV2. Traditionally, sort of was thought HSV1 was above the belt, HSV2 was below the belt, but we know that HSV1 is causing more and more cases of genital herpes, particularly in men who have sex with men and in young women. And it's thought that HSV1 may actually be more than 50% of cases in these populations. Diagnosis of HSV, you don't want to use this Sangster anymore. It's insensitive and nonspecific. Serology can sometimes be something that can be helpful, but it can take several weeks to turn positive. So, but it can be used to confirm clinical diagnosis, diagnose an unrecognized infection. It can be helpful if you're worried that you might have a discordant partners to find out what the 2 different partner statuses are. HSV2 is almost always generally required. Cell culture and PCR are preferred methods if lesions are present because there's a low sensitivity of viral culture, especially with recurrent lesions, and the sensitivity declines rapidly as these lesions heal. So PCR is more sensitive. Primary HSV, all patients with primary HSV should be treated regardless of severity at presentation because people can develop severe prolonged courses if untreated. There are several different recommended regimens listed here. You can extend the treatment if healing is complete after 10 days of therapy. If a patient should know that recurrent episodes are common, on average 5 to 8 recurrences happen per year. Sometimes patients can identify triggers such as stress, fatigue, or even menstrual periods. About 50% of patients experience a prodrome, which can be tingling, itching, or burning, or pain at the site of eruption, and this can happen anywhere from 30 minutes to 48 hours before an outbreak. However, compared to a primary infection, the symptoms are usually less severe, the duration of the viral shedding is shorter, and the duration of the lesions is also shorter. There are 2 different ways to treat recurrent HSV. You can either do a suppressive or episodic treatment. The suppressive treatment is used to reduce the frequency, or you can do it episodically to shorten the duration of the lesions. Suppressive treatment also decreases the risk of genital HSV2 transmission to susceptible partners. There are several different recommended suppressive regimens: acyclovir, famciclovir, valacyclovir. You can see the valacyclovir, there are 2 doses. You could try the lower dose, but some patients require the higher dose to suppress it fully. And then every year you'd want to sort of annually review, is this something that we want to keep going? Episodic treatment that you would take at the onset of any of these prodromal symptoms or the onset of the lesions include the following on the slides. You really want to start within 1 day of the lesion onset or during the prodrome. So again, this is something you'd want to give an advanced prescription and advise them to fill and keep it in their medicine cabinet or somewhere handy, so that way they have it as soon as they feel the prodrome, because the sooner you start it, the better. And then I just want to really briefly just mention HIV. This is way beyond the scope of this talk, but it is clearly a very important sexually transmitted infection, so I'd be remiss to not mention it because it does affect adolescents. In 2011, there were 2,137 new diagnoses of HSV in 13 to 19-year-olds in the United States, and among 20 to 24-year-olds, there were 8,140 new diagnoses. CDC recommends screening for all patients ages 13 to 64. The laws vary from state to state regarding HIV testing, what level of consent, written, verbal, whether you can do opt-in or opt-out, so it's worth checking to see what the laws are in the state where you practice. You usually use a serologic test to detect antibodies against HIV-1 and HIV-2, and then a reactive screening test should be confirmed by a supplemental antibody test. If you're worried about acute HIV, you would also want to perform a nucleic test as well as the antibody test. So in summary, confidentiality is key when treating adolescents. This is something that you want to talk with them and the patient, and getting that confidential phone number is very helpful. In terms of contraception, there are many, many options, and Lark should be considered first line. They are the most effective form we have, and we want to protect our teenagers from unwanted pregnancy. Sexually transmitted infections are unfortunately common, and adolescents need to be screened and treated in order to prevent morbidity from these infections.